This is Radio Health Journal. I'm Reed Pence. This week, why hospitals are getting into the housing business.
Homelessness is a very dangerous health condition. The state of being homeless means that your life expectancy is going to be significantly diminished, to the tune of about 27 years compared to the average American.
The bedrock of keeping the homeless healthy, when Radio Health Journal returns.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy Radio Health Journal, you'll also like Viewpoints, our sister show covering current affairs.
This week on Viewpoints.
We often hold up the people like myself who have, managed to navigate the system as a way to justify the system, as opposed to understanding that we're sort of the lucky few.
How racism is still a problem in 2018.
Then, how early music education fine-tunes the brain.
All that and more this week on Viewpoints.
Listen to Viewpoints on your favorite radio station, iTunes, and Stitcher.
Most people are aware of many of the major causes of illness and death in the United States: heart disease, cancer, lung disease, accidents, and Alzheimer's disease. But there's one that's never officially listed: homelessness.
Homelessness is a very dangerous health condition. The state of being homeless means that your life expectancy is going to be significantly diminished, to the tune of about 27 years compared to the average American.
Stephen Brown is Director of Preventive Emergency Medicine at the University of Illinois Hospital and Health Sciences in Chicago.
Without the stability of a place to lay your head every night, it's almost impossible to tend to anything else. We have what we call here activities of daily survival. So that means panhandling, going to a soup kitchen, finding a place to live, staying away from the police, not getting arrested. Those things, if you think about it, that takes up their entire day. They don't have time for their health care, and they don't have time to do anything else.
If you don't have a place to live, there is no more stressful situation. And they are proven to cycle through very expensive systems of care, like the emergency room, and not just the emergency room, but actual hospitalizations.
That's Shannon Nasworth, President and CEO of Ability Housing, a nonprofit in Jacksonville, Florida, that develops housing for the homeless and disabled.
If you have a chronic health condition and you are not able to go home to a safe bed and get rest and take your medication and keep routine doctor's appointments, that chronic health condition is just going to continue to spiral and get worse.
But even though we now know that housing is as important as medicine or a cast on a broken leg if someone wants to stay well, healthcare hasn't really recognized that housing is any of its business.
If somebody comes in and we think that they have cancer, we'll do everything we can to extend their life or at least make them more comfortable. And the same person coming in with the same age-related mortality ratio, a chronically homeless individual, who's going to live about the same number of years as somebody with cancer, we're going to discharge him back to the street. There's a huge irony in that.
However, that's beginning to change. First of all, Brown says most hospitals are nonprofit charitable institutions, and they're starting to realize that housing for the homeless might be part of their mission.
Why would a hospital pay for housing? Well, for us, it was a baby step into population health. And population health, broadly defined, is taking care of a community or a group of people versus individual care, which is kind of the predominant model right now in the United States.
And if that's not enough to get hospitals interested in housing, well, money talks. Homeless people return for expensive emergency care over and over and are admitted to the hospital far more often than the average person. Brown did a small study and found that chronically homeless people run up an average annual health care bill that's 6 times higher than normal. A much larger study confirmed it.
32% of them were in the 90th percentile or above, ranking their costs compared to other patient costs in our healthcare system. So I think our average patient cost is around $6,900 per year. And these individuals had healthcare costs that were somewhere between $51,000 and $533,000, or I think if you do the math, it's 7 to 77 times more expensive than the average patient here.
Hospitals who treat those patients may never be paid, so there's incentive to keep them healthy. Or the state often has to pay the bill through Medicaid.
There's at least a state cost that's exorbitant. These are what we call superutilizers in healthcare. So in any state that has Medicaid, 5% of the patients there account for about half the cost of the Medicaid budget. And chronically homeless individuals are part of that 5%. So it would make sense, at least from the state's perspective, to create systems of care that would identify these individuals earlier in their homelessness and refer them into permanent supportive housing using the type of supports that means that they're going to be retained in housing. You have to do things in particular ways so that you have high retention rates.
We are conducting a pilot where we were given resources to construct a 43-unit apartment community and target residency to high utilizers of crisis services. So the people who are cycling through our hospitals, our emergency systems, the criminal justice system. In the first year, we were able to do an interim data poll just to assess what are the cost impacts, comparing the 12 months before the person's moved into housing with the 12 months after they moved into housing. Our hospital saw a 63% reduction in expenditure, meaning in the 12 months after a person moved into housing, our hospital spent 63% less on those people than they had in the 12 months prior while maintaining their homelessness. The community as a whole literally saved 50%, including the cost of the housing and the support services we provide. Jacksonville spent 50% less the year after people were housed than the year before when they were homeless.
Those kinds of numbers make hospital leaders and governmental officials listen. Brown says the return on investment for housing can be proven.
The cost of housing and supports and all the food and everything that they'd need for a year is about $18,000 to $25,000. I have one individual here that has accumulated in calendar year 2017 $75,000 in reimbursable costs. So one of the managed care organizations, one of the agencies that pays the insurance for Medicaid here in the state of Illinois, is doling out $75,000 to my healthcare organization alone. And I know she's been to 2 or 3 other emergency departments. So you can imagine just how exorbitant her healthcare costs. But for the investment of $25,000, we perhaps could save, I don't know the total healthcare costs of this individual, but I think I could easily say that I could save an insurance company over $100,000 in prevented cost.
But how you carry out the plan determines whether it's really successful or not. It used to be that housing operators wouldn't give someone a key until after they cleaned up their life and got off of their addictions. But without a home, that's nearly impossible. Traditional models like that result in only about 20% of people being able to stay in housing. The rest wind up back on the street. Now, Nasworth and other operators of housing for the homeless use what's called a housing first model.
The most successful and most cost-effective way to help individuals who are homeless is take them straight from the streets and move them into an apartment. But housing first doesn't mean housing only. Another really key important best practice is called permanent supportive housing. And there's a lot of evidence base around this and a lot of research. And what that means is you get an apartment, you have a home, you have a lease with all the legal rights and responsibilities of a lease. But in addition, you are offered support services. The services are voluntary. They cannot be a condition of the lease, but they are available to anyone who needs them. And candidly, sometimes people move in off the street and they don't need a whole lot of help. Just getting that housing, getting access to health care and behavioral health care, they stabilize very quickly and don't need a lot of ongoing supports, even if they've been on the street for years. Other individuals have very significant barriers, a lot of challenges associated with disabilities, and they're going to need ongoing supports, for many years to come, and that's how they're successful.
Housing First has resulted in a retention rate of 80% in projects where it's used. Nasworth says over the last 3 years, 95% of Ability Housing's residents have successfully stayed in housing for at least a year. She says it's all thanks to adequate support for residents and not demanding that they get cleaned up first.
Housing First says there are no barriers. You move right into the housing and then you address any challenges the person may be having. People think, you're going to move them in and they're going to be allowed to drink. And, my response is, yeah, I drink in my house, so they can drink in their house. As long as they're not violating the lease and breaking the law or anything else, then they have the right to live in their home just like everybody else. It doesn't mean that there aren't any rules. Like I said, they have a lease, so they have to meet all those obligations. They can't be disruptive. They can't destroy property. They have to pay rent. but they have the same rights as anybody else as well. So if they don't show up at an AA meeting or they don't attend a therapy session, that has nothing to do with their lease. They have the right to decide not to avail themselves of those services. If they're abiding by the lease, they get to keep their housing. And it's really been proven to be the most effective way to help people.
Nasworth admits that at first, many of the homeless say they don't want services, but that eventually changes.
For years, people have been making demands and saying they had to do things in order to get housing. And in a way, they're kind of testing us to make sure we're serious when we say, these are voluntary, it's not part of your housing. But if they have a problem, they quickly call us because they don't want to lose that housing. As you can imagine, if you've been homeless and you now have a nice place to live, the last thing in the world you want to do is put that housing at risk.
Brown says the type of support varies. Some people need a little, others need a lot. Some may even need a specific type of housing.
For example, there's a model of care for the seriously mentally ill. It's called a service community treatment, and that's where a caseworker interacts with somebody with severe mental illness 3, 4, sometimes 5 or 6 times a week. They help them take their medication. They help them with life skills. They take them to their doctor's appointments. We are looking at having more of that on the supportive side, sort of community treatment embedded in our supportive case management. But then the other piece of it then, too, is the housing. Some of these individuals need 24-hour supervision and probably need to be in project-based housing where the individual would live with other people with severe mental illness or substance abuse. And there would be case management on site and people that can intervene if somebody's having a psychiatric crisis and that type of project, too.
Support also extends to a person's finances.
Everybody does have the obligation to pay rent. And, one of the things we try to do is to help everybody first access any benefits they're eligible for. So if they have a disability and aren't signed up for disability benefits and Medicaid and the things, we'll try to help them access those. But as soon as we do that, in helping the person set their goals for themselves and their plan to achieve those goals, a key component of that is, what are your employment options? What are the opportunities available to you? What training can we offer so that you can become more economically self-sufficient, with the end goal to help people move out of our housing into other housing in the community. In the end, that's always the goal, is to help the person be as self-sufficient as possible and to move on out of our programs and into other housing in the community as quickly as possible.
The data say providing housing first for the homeless works. It's a win-win for hospitals and others that provide it, and for society at large. Yet Brown and Nasworth admit there's been pushback from the community that sometimes makes projects more difficult to complete.
There is a stigma associated with homelessness and with mental health. We have had community members who had misperceptions of the individuals we were going to be housing and the type of housing we would be providing. We had one particular project where the community thought we were going to be a methadone clinic, or we were going to let anybody move in with any kind of background and they would be selling drugs and doing all sorts of crazy things in our housing 24/7. Really, the only way we've been able to find to help people understand better is to bring them out to our existing housing, to have them walk around, meet our residents, and realize these are people just like you, your family members, your siblings, your cousins, and the housing is just like every other housing in the community.
Sometimes opposition is based on what people see as a moral dilemma.
Essentially, we're giving, in some people's minds, the least deserving the most amount. And I've often had conversations with many people along the political spectrum, and they have offered their very strong opinions to me sometimes. But I think there's a balance here. It's both a compassionate thing to do, and it also saves society money. It's cheaper for these individuals to be in permanent supportive housing with the type of supports that they need. These are not freeloaders, people that are capable of working and not working. These are people that have such significant challenges in their life, they're not able to. And we had a few individuals that have gone back to work, and it's wonderful. And they had a strong desire to do that. And we encourage them, we provide them support, when we help them find jobs, and they're doing well in it, too.
Nasworth says many of her residents tell her they never thought they'd be on the streets, but for an unfortunate series of events. Maybe the car breaks down and they can't get to work, so they get fired. Maybe a family member is hurt in an accident. Whatever the cause, it's almost impossible to get back on your feet with no roof over your head. You can find out more about all of our guests on our website, radiohealthjournal.net. You'll also find archives of our programs there, as well as on iTunes and Stitcher. Or now you can just ask Alexa to play Radio Health Journal. I'm Reed Pence.
Medical notes this week. More than 25 years after the first war in Iraq, more than 200,000 veterans are still affected by Gulf War illness, a syndrome believed to be caused in part by exposure to toxic chemicals. Victims typically suffer from sleep disorders, chronic fatigue, and memory problems. But now a study in the journal Brain Behavior and Immunity finds that curcumin, a component of the spice turmeric, may be able to reverse some of the disease's effects. Researchers say curcumin has also been shown to improve memory in older adults, but they say more testing is needed. A new national survey shows that more than half of lesbian, gay, bisexual, and transgender youth have been diagnosed with an eating disorder. And of those who haven't been diagnosed, more than half suspect that they have an eating disorder. The survey by the National Eating Disorders Association also finds that among those diagnosed, 88% have considered suicide. And finally, plastic surgeons say a lot of people are showing up in their offices asking for a nose job, showing selfies to prove their nose is too big. But a study in the journal JAMA Facial Plastic Surgery finds that most selfies distort the size of the nose by as much as 30% because they're taken from too close a distance. Researchers say close-up selfies are the equivalent of a funhouse mirror. If you want a more accurate portrait, take the picture from about 5 feet away. And that's Medical Notes this week.
Thank you for listening to Radio Health Journal, a production of MediaTrax Communications. If you enjoyed this week's show, please leave a review on iTunes or share it with a friend. You can find more Radio Health Journal stories about health, science, and technology on iTunes, Stitcher, and at radiohealthjournal.net.